Thank you. Welcome, everyone. Thank you for joining us today for MVC's Cardiac Rehab Work Group. We're so excited to have you here. My name is Emily Bear, and I'm one of the site engagement coordinators with MVC, and it's my pleasure to be facilitating this work group with you today. Our agenda for today's work group, first I'm just going to go through a couple of housekeeping notes, some reminders about P4P credit, as we usually do. And then we will hear from Greg Scharf on the impact of organizational structure on operations for cardiac rehab programs. Very excited about this topic. Hopefully it will be informative for you. We will be monitoring the chat, but we'll also host a discussion and Q&A session at the conclusion of Greg's presentation. And then we will finish up with just a couple of MVC reminders about upcoming events. All right, so before I introduce Greg a little bit more, just wanted to review some of those housekeeping items first. This session is being recorded, as you might have heard me request that Rachel start. We will provide you with that recording as well as the slide deck provided by Greg at the conclusion of the work group. You should see that come through in an email that will go to all attendees. Anticipate it within an hour or two after our work group so we can just collate all the resources. Please also ensure that you mute yourself to reduce background noise unless you would like to unmute to ask a question at the conclusion of the presentation. And like I mentioned, we are going to be monitoring the chat throughout the presentation, so feel free to add questions as they come up. We'll collate those and ask questions during the discussion and Q&A session. All right, lastly, for P4P work group credit, just a reminder that we are encouraging active participation throughout Greg's presentation. He has a couple of polls, so feel free to use the raise hand function when he asks those questions or add comments into the chat function. All right, and then lastly, we will be sharing the link to the post-work group survey at the conclusion of the presentation today, so be on the lookout for that in the chat. We will also provide that in the follow-up email if you miss it. Right. And with that, I'd love to introduce Greg Scharf. He's currently the Cardiopulmonary Rehab System Manager for MyMichigan Health. This includes oversight of 9 cardiac rehab and 8 pulmonary rehab programs across the MyMichigan Health system, which serve patients in 25 counties across Michigan. That's amazing. That's a huge spread. He currently serves on the AACVPR education and the Michigan Cardiac Rehab Network advisory committees, and continues to support at Day on the Hill, while previously holding multiple positions within the MSCVPR, including the Northern Region Representative and Vice President. So welcome, Greg. We are so excited to learn a little bit more from you and all of your expertise in the cardiac rehab world. I am going to transfer sharing over to you, so long as I can find my tab to do that. All right, you should be able to share now, Greg.
All right. I appreciate I really want this to be an engaged learning for everybody. So feel free to utilize the chat, raise hands, and looking at open conversations amongst us all as well. So some of the learning objectives today: describe organizational structure and determine how it positively or negatively impacts cardiac rehab programs. Identify opportunities to best support cardiac rehab programs within existing organizational landscapes. And then understanding the anatomy of the referral and the process beyond the order entry and the downstream impact. So again, very interactive. Responses will help us to provide optimal support for programs in the future, best ways to communicate information, those types of things as we address these future needs. So first question, show of hands, raising hands. How many on this call directly manage cardiac rehab operations or have authority to implement change? So I'll kind of move through as everybody tosses their hands up. We'll kind of get an eye of how many of those exist on this call. So I'll let Emily kind of keep an eye on that as we go. So when we look at a lot of the programs, this is where a lot of us feel in an organizational structure. So we're often isolated, misplaced, or misrepresented in the large and complex healthcare structures. There are numerous reasons why this occurs, but today we want to look at the ways we can best understand these limitations and maximize the impact and explore opportunities to improve strategies to overcome these barriers that exist. So the first, so this will be the chat function. One thing I was interested in is where does your cardiac rehab program report to or report through? So interesting, I did this presentation or had this conversation with a smaller group within the state of Michigan, and over 20% of the cardiac rehab programs were structured in a way that they were reporting to a non-cardiovascular related service. So I thought that was pretty unique that what's happening with these 20 when they're not reporting up the same pathway as our cardiology groups. So I think that's a limitation. So for those engaged, please add to the chat what reporting structure your cardiac rehab program goes. And don't be surprised or don't be afraid if it's other or I do not know. That came up as another option as well. Some higher level leaders didn't really know how their programs even reported. So we'll talk a little bit about strategic alignment. So what is strategic alignment is the prudent arrangement of the various internal and external elements of an organization from its business strategy to its organizational structure to best support the achievement of its long-term goals and purpose. Here's an example of our leadership structure in our organizational structure. So personally, we report up through rehab services. We have a great relationship with them. It works well with us. But as we know, a lot of my communications and pathways go this way. So I'm looking at cardiovascular services, our heart failure clinic, open heart clinics, structural heart program, vascular. Those are where our dotted lines typically stretch to. So it's those communications with those pathways and then up from me through rehab services, through professional services, through senior leadership. So creates a unique challenge. We've had ways to implement them things to improve our barriers and getting things accomplished when we report differently as well. So what does misalignment mean? So we're looking at disconnection of strategies and objectives. We have increased redundancy in relationship, which lead to inefficiencies, communication dead ends. One of the big ones is advocates have limited authority to change. So example, cardiology wants workflows that impact productivity, but the leadership group does not have the authority to approve such movements. They can influence change without authority. So that's a challenge as well. And then potential conflicts. One of my examples would be if sharing a gym with physical therapy and OT. Me as a cardiac rehab manager and the PTOT manager both go to our director requesting more space, more equipment. What is the conflict of interest with that, depending on your director's background, what program will be more financially sustainable by the increases, things of that nature. So we want to be careful of those things as well. One thing we're seeing more of, and I'm glad to see this over probably the last 10 years, is systemness approaches. When I worked as a vendor on the patient monitoring side, this was just in its infancy. We'd look at larger health systems and they were very siloed in their operations. So this is an example for us with each integration within our health system. We had vastly different structures coming in for cardiac rehab. So previously the cardiac rehab manager roles and some of the sites that we took on, we had an OB/ER manager that had oversight for cardiac rehab. We had a PT manager, respiratory service supervisor, and then our cardiovascular services manager. So in 4 of those locations, not one level of consistency in how each one of those programs operated prior to MyMichigan taking on those responsibilities. Another, just a little example of where these structures could fall into challenges. So if there's multiple sites, we've got cardiac rehab sites A through E throughout their health systems regions. Looking at their reporting structure, you can see the challenges that each one of these exists. So, so part of this is to kind of take this information back, especially if you're an interlinked health system. How is this communication pathway? What does this pathway look like for your health system internally? And what barriers does that create? So again, do each of your programs operate under the same org structure? Do they have the same operational expectations benchmarking? Are they comparable and applicable across all of your sites? Do your regional locations have support from what we historically hear is our mothership? Do we have support for the regional sites or even external referral sites that may be out of system? And we'll talk a little bit more about that as we go through. One of the things I always term cardiac rehab is we suffer from small department syndrome. We're not large enough in the healthcare structure to support a typical organizational structure. So we tend to skip leadership rungs. We look at, a department of less than 10 can't justify all necessary leadership levels. As we know in the leadership structure, each one of those levels has a key component to what they provide and what seat at the table they're at. And if we're missing those components, that's where cardiac rehab can tend to fall through the cracks in some of those as well. In comparison for MyMichigan Health, cardiac rehab across the health system, a little north of 30 clinical staff, compared to PT counterparts, which have over 1,000 clinical staff across our health system. So we're significantly smaller in the scope and grand scheme of things when it comes to operations. So we're really limited on where we can have leadership in key places. As we talked about, inconsistency in organizational structure within the health system. And even between health systems, as we look at, our organizational structure compared to other large health systems as well. There's a lot of inconsistency across the board. We see this more in rural, small medical centers where leadership is required to have multiple hats. That's where we saw a ER OB nurse manager handed cardiac rehab as a gift in that process. So I think that's one of the things we have to be aware of and consider of when we're communicating and trying to get actionable items done across our health systems and supporting other health or cardiac rehabs that may be outside of our health systems and understanding their struggles. So questions for all of us to think about as we navigate this as well. So who's responsible for your cardiac rehab operations? Is it a director, manager, coordinator, supervisor? What levels are engaged in the cardiac rehab process? What is their clinical background? Do they have cardiac rehab experience? Again, I talked about a lot of times cardiac rehab is a gifted department to leaders. So they may have no level of experience or knowledge in these programs as well. Are they responsible for non-cardiac rehab departments? And are they responsible for non-cardiology related departments on top of cardiac rehab? Who are the cardiac rehab subject matter experts that you lean on? Is there one? Is there multiple within your organization? Again, when we talk about our organization only having 30 clinical staff, that really leaves us a limited number of subject matter experts that can come to the table. So the likelihood that you have a multiple within your hospital is is not as likely as you would see in PT or nursing. Are they attending AACVPR, MSCVPR conferences, educations? Are they members? Are they at the MVC events? Are they part of the Michigan Cardiac Rehab Network? And then what are your subject matter experts level of authority? So your subject, if there's subject matter experts are your clinical boots, they might not have the authority to make changes. And they might be trying to present that to leadership. And how are we supporting them in those endeavors? Diving into the limited availability of subject matter experts. Again, small clinical field limits the number of SMEs. This limits the number of SMEs in elevated leadership roles. A lot of times the subject matter experts come from areas that it's not their primary area of expertise. They learn it secondary down the road if offered with that potential. And again, decreased probability of multiple SMEs within an organization. And I think that's why the MVC and MICR are very, very positive programs to have because we require much more external networking and resources to maintain our level of expertise in these levels or in this program. Leads to a lot of independent decision making for leadership. When you don't have multiple CMEs to toss ideas around, have that communication with, we lead independent decision making, which doesn't always lead to the best decisions. Requires additional and specialized training and knowledge specific to cardiac rehab. One thing that may be of interest as well, looking at our subject matter experts, unfortunately, when we look at exercise physiology and our exercise physiologist, if ACSM or AACVPR certifications are not required in job descriptions, there's currently no governing body that requires continuing ed for EPs. So when we look at this, we want to make sure that we may have clinical staff that has not obtained CR-related CEUs in the last decade. And are we relying on them to be our subject matter experts and drive us into the future? Are we supporting them in getting this education? Either by requiring certifications or supporting the cost endeavors that come along with continuing eds as well. For our RNs, CEUs required to maintain license. There's a lot of access to free credits. Those typically are more generic CEUs to cover that. Again, cardiac rehab related CEUs are generally not free. So how are we supporting that staff and getting this information when there's potentially dollar adds to that and when nurses have access to free credits to maintain their license. And secondary with the exercise physiology, speaking of license, there's currently no state licensures for EPs, which is one of the barriers for not having a governing body that requires continuing ed for that group. All right, we're going to shift gears here a little bit. We're going to look at what I call the anatomy of our referrals. Over the past 10 years, we've seen a tremendous gain in our referral percentage, especially in our main 5 categories. Unfortunately, participation has not had equal trajectory. Johnson has presented previously on this with some data, engaging comes to this continued challenge to kind of match our referral captures to our participation rates, and having a little bit of a disconnect there. I think we need a better understanding of the referral requirements and the processes behind beyond the checks of our MVC referral data analytics box. So what I mean by that is per CMS, we're required for a physician order. APP orders are appropriate with MD or DO co-signatures. Qualifying event must be on the referral or order. So an example, we still receive patient face sheets with no physician order from external surgical sites as this is your patient, this is a patient that qualifies for cardiac rehab. So what we call that is basically an inactionable fact. So it's something we have to take action on before we can even contact the patient. We have to generate a referral. We have to contact physicians on the backside to do that. So we'll get into a little bit more details of that and some examples. So common referral delays. Now, these are some things that we found internally. So on the left is the diagnosis issue. So for a CMS patient, this would not fly through an audit with these two diagnoses listed on the order. And then the second one was an NPP with no cosigner. So our mid-level with no co-signature. So these are not what we call actionable referrals, but unfortunately, both of these scenarios fall under the MET category for referral percentage data. So again, what does this mean? While both of these patients are valid patients, the orders do not meet CMS guidelines. We epic message our nurse pool, resubmit the order. Without the correct diagnosis, all we have is a qualifying patient list. If this is what we receive from an external source, physicians are likely to see one of these fancy things come back their way. So this is just our version of we have a patient that has a misdiagnosis or there's something missing from that information that comes to us. We send this back to the patient for their provider to complete and send back to us. So now we're going back to good old fax timelines. As I get into some of my data, huge shout out to Emily, Julia, and Janet. I've worked with them probably tirelessly on questions and answers and building reports and addendums. This is a great team. They've really helped me to dive into some of our specific data. So I really strongly consider you utilizing them as a resource as well to answer questions that are specific to your department's needs. So thanks again for all the support, and that's where all of this information you're going to see down the road came from that team. So here we go. So the first thing I wanted to look at was where do patients that events originate from MyMichigan Health facilities, where do they receive cardiac rehab? So this is a breakdown of all of the patients that originate within our health system and where they're receiving cardiac rehab. Uniquely for us, 94% of these patients remain within our health system for cardiac rehab care. So really, we only have 6% of our patients that events occur within MyMichigan Center Midland that go to 3 external programs. So we're really looking at an internal process for our patients that come out of Midland. So looking at that, our cardiac rehab program has a tremendous role and impact on the data that's revolving around the surgical site itself. But then when we take a look at it from the cardiac rehab side of things, where do our patients come from cardiac rehab? Looking at the main 5, 58% of our patients are internal referrals. So while we're encompassing almost exclusively all of our patients, we're also getting 41% of our referrals are coming from external. So our patient population almost doubles with the add of external referrals. So we have a tremendous impact on other health systems data when it comes to completion, participation time, the impact outcomes. So that's 40% of what we do as a health system is impacting patients from another health system. So again, what does this mean? Like I said, we're exclusively for our patients, but we also care for patients from other health systems across the state. We have to be aware of that. We have to have an understanding of what that means. And we have to be supportive of each other as we go through this process and understanding that that's where these patients are coming from. And we need to kind of align with some processes as well. So example, for every 100 patients we see, 60% or 60 are coming from MyMichigan Health and 40% are external. So that's almost right down the middle. So that drove another question. Where are our external patients coming from? So again, the analytics team, tremendous job of breaking down where our referral basis has come, the locations, and looking at, okay, so our 27%, our 20%, how do we engage with those health systems or those hospitals to streamline some of the processes that exist, and understanding where that's coming from. So I think it's a twofold question: is where is your cardiac rehab program's referrals coming from, and whose referrals impact them the most? And then from the surgical side and the event side, where are your referrals going and who impacts you the most in those events? I think we have to look at it from both sides of the spectrum to make optimal decisions. Again, wonderful report and data, breakdown of each of our locations, percentage of but it looks at ways with those specific needs as we go. So then my secondary question to this was, I'm curious, what is our post-discharge to first day cardiac rehab variance between internal and external referrals? So this report here was a breakdown of all of those for each of our locations. So what we're seeing is on average an 8-day unfavorable variance between internal and external referrals. That's almost a 25% variance across the board, between the time that we're seeing our patients from internal referral process to external referral process. So what are some ways, or what are some opportunities that we can get to be a little bit closer with those as we're servicing patients that are outside of our health system? So let's go back to this. The unique environment that we have, where we capture, over 95% of our referrals are internal. When we saw this, when we first initiated our Epic auto referral process, these were very, very common. We would see these errors and issues in probably 50 to 60% of the auto referrals that were generated. Because we were managing all of them, we were pretty frustrated with that approach. The nursing staff was frustrated with us, Epic messaging them to change the referral. So we've created some guardrails, we've created some processes and education. We've built that down to, I feel we're about 95% or greater on our accuracy of referrals and MDDO signature or co-signature. So knowing that that's a completely internal process for us, we had a lot of leverage in that conversation. We had a lot of skin in the game when it came to that, because we housed control over everybody's cardiac rehab care that left Midland. So it impacted almost exclusively all of those patients. So it gave us a little bit of a bigger stick to carry around when we had conversations with cardiovascular. So really what I want to talk about, and I want to take some time and pull in some questions from the group. What are some internal barriers that you guys see based off of just your organizational structure? Is the communication getting to those that really impact change? Those that are on the call, and I can't see the raised hands to see how many on this call were available to really facilitate cardiac rehab change. So how are we communicating that? Take a step back and have a conversation with your cardiac rehab teams. They're a lot of the times the ones that are handling these referrals in the work queues. Two things that we see in cardiac rehab, again, a lot of times it's clinical staff that is managing the referral work queue. So they're balancing that between patient care, phone calls, all of these things. So there's a lot of delays. And if we're trying to communicate externally, how do we eliminate some of those delays? How do we look at making sure that the information that leaves our facilities and goes to another cardiac rehab program, once it hits their desk, all they have to do is call the patient and schedule them? Are we taking those steps to making sure that we're setting them up for success? Because most of us are treating patients that are coming from another hospital, and we're impacting them tremendously. So we need to support that process as well. So again, understanding that process for the referrals that leave. So follow your process from the point of which is clicked into Epic all the way through to when the patient gets called. And I think you'll be surprised at how many barriers, how many issues arise from that. But when the check is there in Epic, it shows up on our MVC analytics as a positive. But a lot of times on the backside, we don't see the barriers that are between that checkbox and actively calling the patient. So I encourage each one on this call to understand that process and see where some of those barriers exist. I'm sure you will be surprised at the level of complexity once the work queue.
Thank you so much, Greg. That was very informative. And, we also appreciate the shout out to MVC. Hopefully, those on the call found that data as interesting as we do. I think you left us with some really thought-provoking questions there. Um, and I did want to open it up to see if anyone wanted to, just kind of comment or ask any follow-up questions related to those kind of key takeaways that Greg left us with. Um, just wanted to open up the floor for anybody first before we.
And Emily, I was just looking at the chat, and it was unique. There was some unique
Yeah, I actually went through and I tallied up. Only saw a couple of hand raises for your first question about kind of the decision makers in the room. So I did also want to see if there was anyone who just couldn't quite figure out the hand raise function. I know that's tricky sometimes. But like you, I saw some interesting patterns and some unique responses to where cardiac rehab kind of rolls up into sites. Um, I would say it seemed like cardiology was the most common reported. We also had kind of even amounts of cardiopulm and then something like respiratory or respiratory therapy was another really common one. Another interesting pattern I saw was that there were sort of like dual ownership of CR. So cardio and neurology or like rehab and cardiology. So that seems like another interesting situation that's happening. I did want to ask because we had one respondent that noted that they did not have on-site cardiac rehab at their particular site. I know there is within that system, but not at that particular site. Is anyone else on the call in that boat that, your individual site does not have on-site CR and maybe you're utilizing resources within your system or even outside of your site or system that you're aware of? I'm sure that has its unique, difficulties than a site who knows they have access to an on-site cardiac rehab program too.
I saw Jennifer's question on what is the biggest hurdle to getting patients to participate. Unfortunately, our hurdle may be vastly different from other sites' hurdles. I look at, we can control 60% of our internal process. So our hurdles on that aspect are probably a lot easier than most. So I think that's provider communication. We've done a tremendous job with our surgical team, our mid levels, our discharge planners. Our patients are well aware of the process of cardiac rehab by the time they leave the facility. So we've never had to facilitate, an EP going to discuss cardiac rehab. That's all been handled by our providers, our nurses, and our discharge planners. So they've been a tremendous asset for us. I'm fortunate. Um, they have the buy-in, they have the communication, so we don't have to. So then it leads to our barriers is how do we improve some of these processes for patients that we get referrals from externally? How do we make sure that we have similar participation rates between our internals and externals? What's the variation between those as well? Because that's important for us as well, because those patients are our community. And we need to support them no matter where they came from, and we need to be able to support that as well. So I think it's a two-way street. Is how can we make some changes, but then how can the referral process be improved once they leave your health system, especially if you rely heavily on some of those external locations. So be interesting for everybody to kind of know how many of those referrals leave the health system and how much of this is impacted by others. And are you supporting those others in ways that you can when they're not within system?
Great points, Greg. Looks like we had another question come in from Stacy, just about staffing. Do you staff only EPs in your cardiac rehab program, or do you also utilize RNs?
We probably, I'd say, heavily EP. We have a few RNs, but it is mostly EP.
Well, I wanted to kind of go back to those takeaway questions that you had, Greg. I know we pulled them off the screen, but I've got them pulled up. So your first takeaway question was about internal barriers, um, just related to the organizational structure. And I'm curious if anyone has been thinking about this. Like this, is this something that internally, you're investigating already related to your cardiac rehab program? Um, or is this just like a new idea to most of us on the call?
Another interesting question, Emily, I was thinking if those want to throw in the chat, would be interesting to see how many do you know, and if so, how many cardiac rehab programs are within the health system that you're within? So for us, there's 11 cardiac rehab programs within MyMichigan Health. Do we know that number? What's your just kind of really thinking about what's the engagement in those for us? What's the engagement in those 11 programs with with each other, with our surgical sites? How much do we truly engage even internally? So I think, looking at that is how many are within your health system, and as a health system, do you feel like there's a lot of collaboration between however many that is within your system? I'd be interested to get some thoughts from those in the chat as well as what their feelings are.
Yeah, it's a great question. So for those of you that, are especially a part of a system, And I do see some names that I know are part of systems on the call today. What's your knowledge of your cardiac rehab center accessibility within your system sites?
And if you're standalone, just throw a one up there, and
Mm-hmm.
that creates its own challenges too, because a lot of those ones don't have direct communication with where the referrals are coming from. They have multiple locations. They might have six, seven different referring sites that they're not interlinked with. So how do they have these conversations? How do they support processes when they're not um, interlinked with any health system?
We got a couple ones. Do you have a couple comments in the chat, Greg? I don't know if either of these are things you would want to comment on, or Linda mentions that their site shares space with pulmonary rehab. And since both cardiac rehab and pulmonary rehab programs are pretty robust, the lack of space to grow is something that's limiting their expansion. And I'm assuming their ability to you know, support more patient volume. I know that's something that's come up in previous cardiac rehab presentations is how do you deal with small space or the closure of cardiac rehab programs and not necessarily even having a space to manage any longer. Any thoughts on that?
Big conflicts when you run into those. Definitely, we have that similarity with PT and OT where we share gym space. I think both programs as we grow, we interfere with the growth of the others. So we have to be careful of that as well. I think one of the biggest barriers is our regulatory environment for cardiac and pulmonary rehab. The financial implications of providing cardiac rehab offsite with hospital physician fee schedules. So there's bills out there that I think we really need to focus on to improve that, because growth comes cheaper when you leave the medical center. Medical center space is at a premium. Finding additional square feet is hard when you're talking about a medical center. If we had the ability to purchase, lease somewhere outside of the medical center to provide this service and do it sustainably, we could grow.
Mm.
Our biggest barrier right now is the inability to sustain that financially and open rehabs outside of the medical center. When you're trying to do that with 60% reductions from CMS, and that's a vast majority of our population, how do you do that? You can't. You functionally cannot. Um, my suggestion is if you're fighting with PT and OT, tell them to leave because they can. um, I joke with my PT manager all the time. I'm like, you guys can just leave. I can't. So I think that is a huge barrier of how we can provide care close to home, because we are directly tied to the medical center. I think we really need to look at how we're advocating cardiac rehab care and the regulatory guidelines that are handcuffing us through CMS. And I think we need to really push hard. It's been a long process to get the bills in place. We need our legislators to push that. I think that's my advocate, my soapbox for the day, is to really drive that initiative home.
Yeah.
Because until we can leave the medical center campuses, that's going to be a significant challenge.
I'm going to come back to Sasha's comments. I think that kind of gets to organizational structure, but Dawn noted that within their system, they have multiple cardiac rehab locations, but a lot of those CR locations are not close to where their patients live and thus would be routinely returning for cardiac rehab. And based on MVC's reporting, we've created a custom report for the system. Um, Basically, a lot of their patients are primarily utilizing one cardiac rehab location within their systems because that's actually where they live.
Mhm.
And I'm curious, do you have any additional thoughts related to cardiac rehab programs that are, maybe in other locations that aren't being utilized as much, maybe how to support those locations a little bit more?
I'm thinking maybe utilizing groups like this to find collaborative ways to have these conversations and to connect the dots of where these referrals are going. And then, there might not be ways to directly support them, but there may be feedback loops that they can provide that, can help and say, hey, if we got this, we could see your patients sooner. If we're calling your patients and they're saying that, my doctor says I can't start cardiac rehab until after my 4-week follow-up. What's the provider communication? Are we actually having regular communications with the cardiac rehab programs that are providing the follow-up care? We might not be able to have a direct impact, but we might be able to learn something.
Right. I'm almost imagining a map of some sort to help. Um, had somebody just unmuted? I thought I might have heard someone.
That's going to be for us house for ours, but there's a significant number of yours that we're taking care of post.
Mhm.
So we need to balance that as well. We need to understand those dynamics, and support that process as well. So we need to have an understanding of where the dynamics come from both angles.
Yeah. All right. And I'm just gonna, it looks like our chat is kind of quieting down a little bit there. Courtney mentioned that they have 10 sites, 10 CR sites, but they're also running into that barrier of limited space, being, at the medical centers. Sasha mentioned that, one issue they're running into is that they're very isolated across their system. Internally, the organization structure is challenged due to being split between cardiology and neuro. And then recently had a loss of the director of the program. So it's another, kind of something to keep in mind, I think, as organizational structures are changing. We're also seeing the ability to make moves and changes for cardiac rehab programs is also being impacted. So,
Yeah. Yeah, I look at that as a prime example, a split department or split service line. And then looking at that scenario again, the managers of that cardiac rehab program, what input do they have on the next director, that comes into that? And the history of that, it'd be, very, very interesting to kind of see. If you might have somebody who's been there for 5 years, took an initiative, learned cardiac rehab, now you're bringing in somebody who's going to be the director who may have cardiology specific, neuro specific background. Now do we have to educate and bring them on board from somebody who may have been on board already, or is the previous director not engaged and this is the opportunity to engage somebody new? That's a unique situation that could be there. So it's just ways to look at that. So challenges from both sides to make sure that cardiac rehab has a seat at the table and is part of the conversation.
so I think we will kind of close things out there. I'm going to share my screen and just remind you all of a couple of upcoming MVC events. All right. Okay. So just a reminder, we've got our second June work group coming up on the 26th. That's going to be a health and action work group focused on a continuation of the conversation regarding systemness started at MVC's Spring Collaborative Wide Meeting with our director, Dr. Hari Nathan. We'll also have a rural health work group and a post-discharge follow-up work group in July. So we look forward to seeing those of you that those topics interest there. Okay. Just a reminder, save the date, that MVC's Fall Collaborative Wide Meeting will be in Livonia, Michigan on October 10th. So that's a really early reminder to block your schedules. And then additionally, those of you that are MVC site coordinators, you should have received an email earlier this week regarding the MVC QI or Quality Improvement Survey. This is live through June 30th. And as a reminder for those of you that are P4P seeking, there are P4P engagement points connected to completion of that QI survey by June 30th. Additionally, just a reminder that MVC is currently accepting requests for virtual, in-person, and system-level site visits in 2025. If you're interested in setting up a site visit with MVC, you can use that link. And lastly, MVC is seeking presenters for upcoming 2025 work groups, as well as our fall collaborative wide meeting. We're looking for, like I mentioned, work groups, poster presentation, breakout sessions. So if you have a QI project or a topic that you think would make a great presentation, submit a presentation proposal form to us, and we will work with you to find an opportunity. All right. Thank you so much for joining us today. We're going to have the survey link added to the chat here. There we go. Rachel's added that to the chat. So we'll give you a couple of minutes to grab that. Like I mentioned at the beginning, that link will also be shared in the follow-up email, which should be coming out before the end of the day. So if you are unable to grab that right now, don't worry, it will be provided.